Although we face tough circumstances these days, we can still connect and reach out to one another, even if we are in different governorates, as long as we have the same goal, which is to help more patients receive the better treatment and enjoy extra moments with their beloved ones. So, welcome to The Live, the premium live platform for cardiologists. Our live virtual webinars with open windows for double-way communication, discussions, and questions over a period of 6 months, starting on 11th of May. Hosting the top experts in cardiology, Professor Mohammed Subhi, Professor Ashraf Rida, Professor Ihab Atiyah, Professor Hisham Abu Al-Anin, Professor Tariq Zawawi, Professor Nabil Farag, Professor Mohammed Satiha, Professor
Hani Raghi,
Professor
Hussein Andil,
Professor
Ayman Abu Al-Majd.
Stay tuned. Brought to you by Bayer.
Good afternoon, everyone, and it's always a pleasure to be meeting you here. And I would like to welcome each and every one of you and thank each and everyone for accepting the invitation to be here today. As well, I would like to thank and appreciate the work of our eminent panelists today. We have on the panel today Professor Tariq Zawawi and Professor Ihab Atiyah, two eminent important figures in cardiology in Egypt and the Middle East. And always would like to bring up you the key figures, share with you the good clinical practice and how to utilize the best treatments for your everyday patients that you see in the clinic. As you know, the series of events or the series of webinars is under the umbrella of the Live project. The Live project is a project that we are presenting chapter 3 today, where the eminent professors of cardiology, they worked a lot to create you this kind of curriculum and deliver you on series of online webinars and events. So I wish you to have a pleasant day today and have the maximum of it. And I appreciate you type in your question and answers, and our eminent professors will be answering it to you by the end of the presentation. By saying this and saying thank you, I would like to move over to our eminent panel today and wishing you a pleasant chapter and a pleasant presentation for the live episode for today. Thank you so much.
Bismillah ar-Rahman ar-Rahim. I would like to thank Bayer Company for inviting me to be with you for this virtual webinar. And also I would like to thank Bayer for sharing with me Professor Ihab Atiyah, Professor of Cardiology at Ain Shams University, to be with me for this meeting. And I hope the future meeting will be a physical meeting because of we are in era of corona infection, unfortunately. According to the novel anticoagulant or DOAC, we have a lot of anticoagulant before. We use warfarin, and this era of new anticoagulant, and there is a debate for the efficacy and safety of this DOAC. And my presentation today is to prove the efficacy and safety of DOAC in versus to warfarin in patients with non-valvular atrial fibrillation. I present in brief a patient, a clinical scenario we see every day in the clinic. Female patient, 77 years old, presented with non-valvular atrial fibrillation, diabetic. The patient is diabetic with low body weight, the body mass index 22, hypertensive, and CKD. The GFR is 46 milli per minute. As we know, the prevalence of atrial fibrillation increases with age. Nowadays, we see a lot of patients with non-valvular atrial fibrillation. The definition of non-valvular atrial fibrillation, the atrial fibrillation excluding the moderate to tight mitral stenosis and the prosthetic valves, prosthetic, mitral, and aortic valves. Otherwise, considered non-valvular atrial fibrillation. Non-valvular atrial fibrillation increases with age, and the patients above the 80, the prevalence of atrial fibrillation reaches 8.8 according to the Framingham Heart Study, and also the incidence of atrial fibrillation increases in both women and men, and with higher prevalence in men, and the relation is curvilinear with the age for men and women and the total. Also, the risk of stroke increases with age, whether the patient has atrial fibrillation or not. If the patient has atrial fibrillation, the risk of stroke becomes high. As we know from this study, the stroke rate percent per year increase with increasing age, with more incidence for patients above the age of 75. Go back to our patient. When we face a patient like this, patient diabetic, hypertensive, CKD, with non-valvular atrial fibrillation. So we have to decide this patient to receive oral anticoagulant to prevent stroke or not. Before we decide this, we have to calculate what is called SHAD-VASc score. Let us see what is the SHAD-VASc score of this patient. It is 3, 4, 5, or 6. What do you think? Also, according to the SHAD score, we have to calculate the annual risk of stroke for this patient in order to estimate the burden of ischemic stroke for this patient. Let us see what is SHAD-VASc score. SHAD-VASc score, this score includes congestive heart failure, hypertension, age more than 75, diabetes, stroke, evidence of vascular disease, or the age between 65 to 75, or female 6. And this score, if the patient has 2 or more, is considered at risk to develop ischemic stroke. So let us see what this patient. This patient is hypertensive, age more than 75, 2, diabetic, 1, no stroke before, no vascular disease today, and the female 6. So the score of this patient is 5. Right. Let us see the annual risk of the stroke of this patient. The annual, according to this, the risk of bleeding and the risk of thrombosis. Here, the risk of bleeding based upon Hess blood score. What do you think? The score 2, 3, 4, or 5? This is what's called Hess blood risk score. Hypertension, get 1 point. Abnormal renal, 1 point. Stroke, no previous stroke. Bleeding, no previous bleeding. Labile INR, no. Elderly, so the score 1 for hypertension, 1 for CKD, and 1 for the age. The score is 3. 3 score has blood is considered at high risk of bleeding, 3 or more. This patient is at high risk of ischemic stroke and at the same time at high risk of bleeding. Type. Based upon the data of this patient, shall we give or should they give the patient oral anticoagulant, warfarin or DOAC? To give warfarin or DOAC? Or the first question, to give oral anticoagulant, and if decided to give oral anticoagulant, which oral anticoagulant to give? Warfarin or DOAC? In brief, the warfarin, there is a lot of problems with warfarin. Warfarin, delayed onset of action, and even after withdrawal, it takes a long time to wash out from the blood. Narrow therapeutic window below 2 INR, there is in case of thrombosis, ischemic stroke, and above the INR 3, there is a risk of bleeding. So the drug-drug interaction, bioavailability is low. A lot of problems with warfarin. So the what's called DOAC or novel anticoagulant had fast onset, characterized by fast onset of action and no drug-drug interaction, needs no routine addition monitor. The problem with warfarin, it needs regular monitoring by INR, and in a lot of patients, INR is what's called the labile. INR is variable for many reasons. So with the use of NOAC, the patients has improved the quality of life and improved the benefit risk profile. And according to the guidelines, the European Society of Cardiology Guidelines 2016 recommended that oral anticoagulant to prevent thromboembolism is recommended for all female with shared vascular score 3 or more, the class 1 recommendation. Our patient is a female with shared vascular score 5, is class 1 recommendation to receive oral anticoagulant. If male, shared vascular score 2 or more. Type. Which oral anticoagulant? These guidelines recommend NOAC in preference to vitamin K antagonists. Apixaban, dabigatran, indoxaban, or rivaroxaban, provided that the patient has no valvular atrial fibrillation, or tight mitral stenosis, moderate to tight mitral stenosis, or prosthetic valves. Also, the American Guidelines 2019 recommended the same class 1 recommendation level of evidence A, that NOAC are recommended over warfarin in patients eligible for NOAC. So we decided to give for this patient NOAC, and this trial published in 2018 show the effectiveness. We have when we give a drug, we have to give a drug to be effective, safe, and cost effective. This is very important. The effectiveness and safety of DOAC compared to warfarin in real world experience. This paper published in JACC 2018, and they concluded that warfarin or DOAC were more effective than warfarin, but this effect was most pronounced in low risk group. Let us see the results. This is the hazard ratio for cardiovascular events or death, stroke, or systemic embolization, and apixaban versus warfarin, rivaroxaban versus warfarin, dabigatran versus warfarin, and all in favor of the use of DOAC. Also, the safety, any bleeding events were in favor of DOAC. And this is a meta-analysis. I will mention about 3 meta-analyses. This is meta-analysis for all the trials of DOAC versus warfarin as regards the efficacy and safety. And this trial to test the effectiveness and safety for preventing stroke and systemic embolization. 3 major trial, including more than 44,000 patients, 22 with receiving new oral anticoagulant, and 22,000 receiving warfarin, and follow up up to 730 days. And the results of this meta-analysis of the trials of these drugs, RELI, ROCKET, Aristotle for ROCKET for rivaroxaban, and RELI for dabigatran. All these trials, the meta-analysis of this trial, showed that the all-cause stroke and systemic embolization was in favor of DUAC. Ischemic and unspecified stroke, 13% in favor of DUAC, with 13% risk of ischemic stroke in comparison with warfarin. Even the hemorrhagic stroke, 55% risk reduction of hemorrhagic stroke compared with warfarin. So in favor of DUAC. And not only this, but the intracranial bleeding was in favor of DUAC with 51% risk reduction of intracranial bleeding. All these demonstrate the efficacy and safety of DUAC versus warfarin. However, there is some GIT bleeding in favor of warfarin. And the conclusion of this meta-analysis, that this meta-analysis published in 2012, and the conclusion that new oral anticoagulants were more effective than warfarin for prevention of stroke and systemic embolization, and with decreased risk of bleeding, and they appear to have a favorable safety profile, making them promising alternatives to warfarin. And based on this trial and meta-analysis, the guidelines recommend, as I mentioned before, the guidelines recommend the use of DUAC in preference to warfarin in this group of patients. There is another meta-analysis to assess the efficacy and safety versus warfarin in atrial fibrillation. And this meta-analysis published in 2014 in Lancet. Also, more than 42,000 patients receiving DUAC and more than 29,000 patients receiving warfarin. And the primary outcome was stroke and systemic embolization, with resulting in 19% risk reduction. Major bleeding, no significant difference. The secondary outcome, hemorrhagic stroke, 51 risk reduction in favor of DUAC. All-cause mortality, 10% risk reduction in favor of DUAC. Even intracranial bleeding, even the major bleeding, however, there is some increased GIT bleeding. A third meta-analysis published 2018, the first published 2012, the second 2014, and the third systemic review meta-analysis published 2018, and also the outcome, stroke, systemic embolization, any stroke, hemorrhagic stroke, death from muscular causes, MI, all these outcome in favor of the DUAC. The bleeding, major bleeding, fatal bleeding, intracranial bleeding, also in favor of DUAC. There is some increase of GIT bleeding in favor of warfarin. Conclusion of this meta-analysis that DUAC were associated with superior or at least comparable efficacy profile and lower odd ratio for bleeding complication compared with warfarin. And patients receiving DUAC for non-valvular atrial fibrillation is effective and safe. Let us ask this question. Do you think that rivaroxaban is an effective tool for preventing stroke in this elderly patient with an acceptable bleeding risk? As I mentioned before, our patient is at high risk of thrombosis and at high risk of bleeding. And as mentioned, described that DUAC is more effective and more safe than warfarin. As concerning the rivaroxaban, this group analysis from Rocket atrial fibrillation for patients with 75 years old or more, and found that the 20% risk reduction of stroke and systemic embolization. And also, the hazard ratio for major bleeding was non-significant. And however, the hazard ratio for fatal bleeding was 55% risk reduction. Fatal bleeding, 55% risk reduction compared to warfarin. Sorry. And also the intracranial hemorrhage, 20% risk reduction in favor of rivaroxaban. This subgroup analysis of ROCKET trial revealed that rivaroxaban by the dose 20 milligram, unless the patient has CKD, this dose was most effective for reduction of ischemic stroke and systemic embolization with a large margin of safety as regard the fatal bleeding and intracranial hemorrhage. Always we fear of using DOAC in patients at high risk patients like the elderly, as we showed before. Let us go for this trial published 2019 in September, demonstrating the efficacy and safety of DOAC in patients with at high risk of thromboembolic. And this trial divided the patient into 3 groups. Group with SHAD VASC score 3 or more, this is including more than 31,000 patients. Group 2, elderly, more than 75 years old, including 24,000 patients. And the group 3, including heart failure patients. And as we know, heart failure is a hypercoagulated state and at risk to develop thromboembolic stroke. These 3 groups of patients, and let us see the results. Stroke and systemic embolization in patients with SHAD VASC score 3 or more in all the trials. Were in favor of DOAC versus warfarin. The risk index was lower. And the conclusion of this subgroup that is that the highest frequency of SHAD VASC score 3 or more of patients treated with rivaroxaban was 87%. The highest group with SHAD VASC score was in the ROCKET trial using rivaroxaban. And the risk index value for major bleeding was lower as compared to other. And also in the RELY trial using dabigatran, the major bleeding with dabigatran was 5 times higher than rivaroxaban. Concerning this subgroup, the best drug to use is rivaroxaban in high-risk patients with SHAD VASC score 3 because of higher efficacy and lower bleeding risk, especially compared with dabigatran. The second group, the elderly. As mentioned before, the elderly in the ROCKET trial showed benefit and safe efficacy and safety, and this is the subgroup of patients in all trials. The risk index was in favor of oral anticoagulant, and the conclusion of this study, the elderly patients more than 70 years or more enrolled in this 4 randomized trial, the prevalence or the incidence was up to 43%, and the highest frequency was in ROCKET trial. As I mentioned before, the elderly in ROCKET trial reached more than 80%. Bleeding risk index was lower in patients treated with rivaroxaban as compared to other DOAC. So the effective and safety profile is high of rivaroxaban subgroup. The third group of this mega trial, the patients with heart failure. And as I mentioned, the heart failure is hypercoagulable state, and the risk of thromboembolic is high. And also in most of the trial, especially the Rocket and Aristotle trial using apixaban in favor of DOAC. And the conclusion of this in the percentage of heart failure patients in this mega trial reaches up to 60% across the 4 studies, and the patient treated with rivaroxaban showed bleeding risk index was lower than bleeding risk index of apixaban, dabigatran, and indoxaban also. And the conclusion of this trial, rivaroxaban showed better safety with lowest risk index of major bleeding as compared to other DOAC, with similar to that of warfarin in patients with shared VASCO score. Where risk index of the other trials is about 3 times higher than the risk index from the Rocket trial. This same for elderly and heart failure. So the rivaroxaban is safe in patients with heart failure, in elderly, in patients at high risk of thromboembolic manifestations like the shared VASCO score 3. Another trial for efficacy and safety in elderly, and this trial also published 2019. And this trial برضو also can testing the stroke, major bleeding, and the major adverse cardiac events, myocardial infarction, and all-cause death, and concluded that apixaban was associated with lower rate of stroke, systemic embolization, major bleeding, and the major adverse cardiac events. Dabigatran was associated with lower rate of major adverse cardiac events. Rivaroxaban was associated with lower rate of stroke, systemic embolization, and the major adverse cardiac events. Let us go back to this our patient, and these can patients' life be protected in addition to stroke prevention? Not only stroke prevention, but to improve mortality. We aiming to improve mortality, and as we know, the patient is diabetic. The patient is elderly, diabetic. Diabetes is considered as an independent risk factor for stroke in patients with non-valvular atrial fibrillation. And this subgroup analysis, Rocket atrial fibrillation trial, showed that the stroke incidence is lower versus warfarin, and also the cardiovascular death, 20% relative risk reduction compared with the patient, as we know, elderly, diabetic, so the DOAC is safe. Rivaroxaban can be used safely and effectively. What about the kidney function? Because the patient is CKD, the GFR 46. Also, this meta-analysis regarding the safety and the efficacy of DOAC, and DOAC had greater clinical benefits than warfarin with respect to the renal function, with lower risk of stroke and the major bleeding. If the data about specific DOAC has subgroup analysis data in patients with renal impairment. Also, all these trials, subgroup analysis of all these trials assessed the efficacy and safety in patients with CKD. And as we know, the dabigatran, 80% renal excretion, so is risky in patients with CKD. And the Rocket trial, the highest incidence with moderate renal impairment is the other trial. And rivaroxaban and the renal impairment in subgroup analysis showed that rivaroxaban was event rate was significantly lower versus warfarin, even in patients with GFR below 50. The risk reduction for stroke and systemic embolization was 14%. Also, in patients with moderate atrial fibrillation, the safety in patients with moderate renal impairment, the safety of rivaroxaban was, as regard the organ bleeding, intracranial hemorrhage, and fatal bleeding, showed relative risk reduction of bleeding 61% versus warfarin. Not only this, and this trial or this subgroup analysis revealed that the safety of rivaroxaban, especially in patients with CKD, not only the safety but also to prevent duration of renal function and to prevent acute kidney injury and to prevent or delay the end-stage renal failure with the need for hemodialysis. 18% risk reduction to develop end-stage renal failure and hemodialysis, and 17 risk reduction of acute kidney injury. And this is unique for Xarelto. And the guidelines recommend that NOAC, particularly dabigatran and rivaroxaban, may be associated with lower risk of adverse renal outcome than warfarin in patients with atrial fibrillation. Our patient, go back to our patient is underweight with low body weight. Is it safe to use DOAC in patients with underweight? To answer this paper published in JACC 2019 for patients weighing from 50 to 60 kilogram, all the endpoints, stroke, hemorrhagic bleeding, GIT bleeding, major bleeding, all cause deaths, all in favor of DOAC. Even the extreme low body weight below 50 kilogram, also in favor of DOAC. Another risk patient, high risk patient, is patients with liver disease. And this paper published in 2019 comparing the safety and efficacy of DOAC versus warfarin in patients with moderate liver impairment, and showed that all in favor of DOAC. In conclusion, DOAC have an improved efficacy and safety ratio, predictable effect without the need of routine blood monitoring, fewer food and drug interaction compared with warfarin. The phase 3 DOAC trials have shown that these drugs are associated with 12% risk reduction of mortality compared to warfarin, 20% risk of stroke or systemic embolization, and 50% risk reduction of intracranial hemorrhage. Thank you.
Good evening, everyone. I would like to share with you some important practical points that we face when we are treating our patients with the new oral anticoagulants. And it is very well known that the patient compliance, whether it's to NOACs or other drugs, is an issue. And it faces us all during our everyday clinical practice. And what's important, in addition, is how we educate our patient so that they can become more adherent to treatment, especially with NOACs. So today I'm just going to focus on some of these practical points. We all know that NOACs have overcome a lot of the inconveniences of warfarin, but because we are not monitoring the anticoagulant efficacy like the INR, so with the rates of non-adherence may be equal or even higher than warfarin. And it's an important concern, because if they are non-adherent when we are prescribing the NOACs for the long term, so the purpose of giving the NOAC with preventing stroke will not be there. We will not have the benefit of preventing stroke or systemic embolism. And we all know that the therapy depends on the patient's self-management. The patient is managing himself, and he is giving himself the medications. So this is an important issue, is the non-adherence to anticoagulation. And although it hasn't been shown that the overall adherence with the NOACs is associated with the stroke risk, but we have seen from the warfarin studies that the gaps in therapy are related to an increased risk of stroke. So it's important to make sure that our patients are completely adherent if possible. The safety and efficacy of any medical therapy depends whether they take their medications as we prescribe it, yes or no. This is quite important. And poor medication adherence has been found with all chronic drugs, all chronic medications. They have almost a high level of non-adherence, such that 28% of all new prescriptions are unfilled. They are unfilled by the patient. And those that obtain the medication, the rate of non-adherence varies from 25 to 55%, which is quite high. So if you say that 28% do not get their prescriptions, we have like 70% who get it, and if 50% of them do not adhere, so you're talking about 35% of all your patients may be the ones that are adherent to medication, which is quite dismal. There are a lot of factors responsible for the poor adherence, and it's common to all patients with chronic medications, including the NOACs. So let's look at some of these reasons of non-adherence. There are a lot of factors. Lack of adequate knowledge about why I'm taking this medication and what is the goal that the doctor wants to achieve. The beliefs about the medication, the patient's beliefs about the medication, whether this medication is risky or not for him. He hears from his friends, his colleagues, that maybe these medications are risky. The complex regimens that are sometimes difficult to manage, because don't forget, these patients are not only on NOACs, they are taking a lot of other medications as well. What is most important is the side effects and the cost associated with these medications. These are some of the effects. There are different types of therapeutic non-adherence. For example, failing to have the prescription, like I said, dispensed. 28% do not fill the prescription when they get it, or renew it. When it's finished, they don't renew it. They keep forgetting dosages. They do errors in dosing. They do not take the drug properly. They mix it up, whether when we tell them, for example, with the Xarelto 20, take it with food, they take it on an empty stomach, and so on. Errors in time and frequency of administration. And some of them, they just get bored and they prematurely discontinue the drug regimen. All this is very important because it not only affects the patient's health and endangers his life, but also dramatically increases the financial cost of the public health services. Because when these patients get ischemic strokes or systemic embolization, they are going to be hospitalized with a lot of expenses to the public health care system. So how can we improve adherence in our Egyptian patients? I'm giving our Egyptian patients as an example, but it could be applicable to other patients, of course. Well, we need to enhance intervention strategies, like we need to reduce the pill burden or pill load that we give to our patients as much as possible. For example, like I'm going to say later, if we can go to a single daily dose is always better than taking dual dosing or more. We have to explain the disease to the patient to minimize his depressive symptoms, because sometimes the doctor will tell him you have to take this medication for life, and the patient will go into depression. We also have to make sure that he has an access to the free services for the health insurance, for example, particularly to those with low socioeconomic status, which are a lot in our country. We have to give more attention to our atrial fibrillation patients who live in rural regions, which have difficult access to get the medications compared to those living in the city. So when we look at the factors and concentrate on patient-centered factors like marital status, family support, the socioeconomic level of education, and so on, and the drug-related factors, I'm going to try to mention all of these in particular. When we start with the patient-centered factors like marital status, it was noticed that those who are married are more compliant because maybe the spouse would positively influence that the patient takes his medication accurately. And that's why we found that in married patients, the patients are more compliant than those who are living alone. Also, education of the patient. The more the patient is educated, he tends to appreciate and understand the consequences of not taking his medication. We found that illiterate patients cannot read or even distinguish their medication. They mix their medication. They can take a wrong medication altogether, which would put him at risk besides non-adherence. So illiteracy is negatively affecting the patient's medical knowledge as well. Family support is very important because when you have family members who give emotional support and they help the patient be adherent to the treatment, this is very positive. And it also helps in reducing the negative attitude to treatment. When the patient gets bored from taking the medication, maybe the family members will help to support him to keep continuing on it. There are other patient-centered factors like age. We all know that elderly, especially with increasing age, the degree of adherence goes down. They have memory problems. They have some dementia, maybe Alzheimer's disease, maybe vision and hearing problems would increase the potential of making mistakes while taking their medication. So the age is very important. Also, it is very common among elderly patients in most societies that they have these statistics, not only in Egypt. And that's why similar findings were made in other countries by a lot of other researchers. When we look at drug-related factors, like I said, the complexity of drug regimen, this will affect the rate of compliance. The more you increase the number of daily dosages, the less will be the adherence. So it's better to always simplify the medication dosing in order to get a better adherence. And the presence of side effects, maybe the patient is afraid or experienced a side effect, which made him worry from that medication, and he is going to stop it without letting you know. And some patients even switch the medication without telling you that they switch to another medication because they don't know how to cope with the side effects. So this is our issue. Like I'm going to say later, we have to teach our patients how to cope with the side effects. So this is an important issue, once versus twice daily, which is related to compliance. And in an interesting study by Andrade et al. In 2015, when they looked at the self-reported patient survey for adherence with the NOACs as well as warfarin, when we look at the once daily dosages like rivaroxaban or warfarin, you find that 94% of these patients were adherent with once daily dose rivaroxaban, and also 86% were adherent with warfarin. Compared to dabigatran and apixaban, those that require twice daily, we found that the adherence was around 70% twice daily. We also notice that there are patients, like I said, who take the medication in the wrong fashion. They take, for example, rivaroxaban twice daily, 6%, that's mistaken, as well as 14% take warfarin twice daily, and the opposite. There are like 30% that take dabigatran and apixaban once daily. So it's important, again, how you explain the medication to your patients. I'm sorry for this busy slide, but we try to look at important points. An important point is the cost of treatment, and I'm concentrating on that because it's crucial in Egypt. The direct and indirect costs of the treatment, it's very important, and it will influence the patient's commitment to be adherent to the medication. And so those patients who do not have insurance coverage or those who have low income, these are more likely to be non-adherent. So the cost of the patient's medication is very important, and you have to help him resolve it, whether by co-payment assistance program, like some health insurance programs, they allow co-payment by the patient. And if the patient's health plan also can maybe cover most of the expense, this would be the best approach, We are lucky here in Egypt that there was a new strategy by the Ministry of Health in Egypt these days in order to optimize medication costs for the majority of chronically ill patients. And for example, with a drug like Xarelto, they are helping subsidize the price of the drug so that patients may end up paying only something like 40 Egyptian pounds per month, which is a very small fraction of the actual cost of the drug. So these programs are very important and have a positive impact in the adherence and compliance of our patients. So in order to achieve an improvement in medication adherence, we have to make sure that we educate our patient about the disease. We have to spend some time with him in the clinic, and we have to evaluate his socioeconomic level and ask him directly, can you afford this medication? We have to tell him the cost per month and if he can afford it. If not, we have to let him know there are other alternatives. Like I said, the Ministry of Health, some co-payment from health insurance programs. We have to also tackle this because some patients will be shy and they will sit in front of you in the clinic and tell you, don't worry, doctor, I can afford it. And actually, after a month or two, they will stop taking the drug. So you have to be very frank and explain exactly that this is a drug long-term. And if you can't afford it, there are other ways that can help you. This is very important for the doctor to explain to the patient. You have to simplify the drug regimen, like we said, by reducing the number of drugs taken as much as possible. So, an important issue is the patient education, which is our responsibility as physicians. We have to make sure that we educate our patient. We have to try to guess the level of his knowledge about the disease. We ask him when he's sitting, what do you think the risk of atrial fibrillation is? What is atrial fibrillation to do to you? And you wait and listen. And I assure you, you will be surprised by the answers you're going to listen. And you have to try and simplify the causes of the disease, the principles of drug therapy and complications, and the benefits about the new drugs that we're giving him. And all this we have to educate our patients about. We have to see why they are not adhering. It's because maybe they are not understanding the role of their therapies. They don't know the disease. They don't know, they think it's just irregular heartbeats. I'm feeling palpitations, that's it. You have to make sure they understand the disease, the consequences of poor adherence, and you have to make them understand why they come to your clinic, why is it important to come for follow-up visits. And some patients also have the belief that this medication is only required intermittently. So they stop the medications and they test themselves. They see, well, what will I do without the medication for a while? I'm sure you all know that we have seen this with the cholesterol medications. I've seen a lot of patients who stop cholesterol medications and they go and test themselves and see if the cholesterol is better or not, and they do self-testing. So a lot of patients, they try to test themselves. For these reasons, you have to educate the patient about really his disease and the value of the therapy that he's receiving. So what should we do when we prescribe NOACs for the first time? Well, you have to take time from your busy clinic. If you're too busy and you have a good assistant, maybe you can train him to educate the patient about his atrial fibrillation, the risk of developing a stroke, and how to protect himself. In simple language, you have to tell him that the problem is not just an irregular heart rhythm, that the heart is beating irregularly, but no, you have to let him know that the blood cells may collect and stick together, and this may cause the formation of a blood clot that can travel in the bloodstream and go to the brain. And if this clot is large enough, it may block an important artery supplying the brain, and you can develop a major stroke. And you can give him this knowledge and reassure him at the same time that oral anticoagulants are here to help prevent such strokes by causing the blood to take longer to clot. Also, when we prescribe NOACs for the first time, there is a lot of things that we should do. I'm not telling you to educate the patient about his SHADS-2 VASC score, but I make it a point to write on the prescription of each patient his SHADS-VASC score. Why I do this? Because he asks me always, maybe on the first or second visit, what is this, doctor? So I try to explain in simple language that this is your risk of developing a stroke. and I try to explain hypertension, age, congestive heart failure, etc. So you try to simply make him aware of the risk of developing stroke. You have to explain the advantage of a NOAC compared to warfarin and why they are easier to use and maybe safer to use than the NOACs, and they are not associated with limitations in food. They can take their green leafy vegetables if they want. You just let them avoid the activities that are risky if they fall or have a serious injury. You also have to make sure the patient has a normal renal function, as we heard from Professor Tariq, and we have to let him know that if he's going to undergo surgery, he needs to stop his NOAC 2 days before if he's got a normal renal function. And we also warn him from taking non-steroidal anti-inflammatory drugs or aspirin together with a NOAC, and that this will increase the risk of bleeding, because I have a lot of patients that come to me taking aspirin together with a NOAC, and unfortunately it's a physician who wrote it for them. So unless there is an absolute indication for the patient to take a NOAC as well as an aspirin with or without clopidogrel, for example, a patient who just had a coronary artery stent implanted, that's okay. Otherwise, they should not have aspirin with the NOAC. Also, you have to make sure to monitor the patient's kidney function regularly, and he should come and repeat his creatinine clearance repeatedly, so you are sure that the dose is still valid for this patient. And finally, like I said before, the cost of the NOAC. You have to frankly speak with your patient about the cost, the insurance company that he has to cover his cost, or if he will go to the public health insurance to help him with the cost of the medication. Also, you should warn the patient from things that he should take care of. If he misses a dose of rivaroxaban, you can take a dose as soon as you remember, but do not double the dose on the same day. Never miss a dose or run out of medication, always to make sure that he has his medication, particularly when he travels out of home, and to renew his prescription regularly, not to leave a gap between filling the prescription. And it's important to take the medication exactly as described. For example, when I tell him take it with dinner in the evening, I mean to take it with food in the evening. So I have to be very specific to explain to him that the 20 milligrams and the 15 milligram dosage, the biocompatibility and availability is better in the presence of food. And that's different with the 10 milligram and the 2.5. They are not related to food. So I have to be very clear. Also, we have to reassure him that there are no foods to avoid. So if he wants to take his green leafy vegetables, he can take them. And an important point is that the drugs are to be taken for atrial fibrillation patients for the rest of their life, or until the doctor tells him to stop if there is a particular reason for doing that. The patient should be told to immediately seek medical attention if he gets, for example, vomiting of blood or coughing up of dark brown stomach content, if there is any hematuria or black or bloody stools bleeding from the rectum, if he develops a severe or unusual headache or neck stiffness, then or weakness in the muscles, he should immediately seek medical attention. Any other visible bleeding that will not stop, if he's excessively tired or weak or dizzy, if he falls, has a serious fall or an injury to the head, if there are severe nosebleed, I'm not talking about minor nosebleed, I'm talking about severe nosebleed that does not stop within 10 minutes, he should seek medical attention. And we should give our patients clear and simple instructions to take the medication every day without missing any dose, to look out for signs and symptoms of bleeding, to provide information for all his health care providers that he's taking a NOAC. This is a very important point, because I get sometimes telephone calls from a lot of dentists. They have the patient sitting on their chair bleeding from, they took off a tooth and they were not aware what the name of the NOAC was. They don't know that this was an anticoagulant. They went ahead and removed the tooth and extracted his tooth, and now there is severe bleeding and they don't know what to do. And they call us on the phone for help. So you have to make sure that the patient tells all his healthcare providers that he's taking a NOAC that is quite effective. so that they should stop it before they do any intervention. You have to educate the patient and encourage him to read more about his disease of atrial fibrillation and NOACs. And again, like I said, if bleeding occurs, to seek medical attention. And finally, and I believe this is my last slide, you have to tell him what not to do. You have to explain to the patient never to double up a dose to make up for a missed dose. If he misses a dose, he doesn't take double dosages. Not to stop taking his NOAC without asking his doctor first to take permission, and not to start taking any new medications or supplements or herbal remedies without checking with his doctor. And this is very common in Egypt. We get our patients, they never tell us that they went and bought herbal remedies. They go to the guy we call al-Attar in Egypt, and they buy herbal remedies, or they get supplements over the counter, and they take them without telling you. They don't think that it's important for you to know, and this can sometimes interfere with the medication and cause problems. So we have to educate our patients fully. And to conclude, I just would like to make sure that it is our responsibility that patients become adherent. We have to educate them. We have to tell them about the nature of the disease and the importance of medication and all the tips and tricks of how to safely use the NOAC. And finally, I'd like to thank you for your attention, and I'll be happy to take any of your questions. Thank you very much.
Thank you, Professor Ihab, for your elegant presentation, as well for Professor Tariq. And let me share some questions. دكتور طارق، حضرتك سمعنا؟
ايوه معاك.
طيب تمام. Yes. طيب دكتور طارق, there is a question regarding the patients with non-valvular AF. Well, type of AF is considered paroxysmal AF. So there is a question: is that patient should get an anticoagulant or not?
Yes, the risk of stroke for paroxysmal atrial fibrillation is the same as risk of stroke with those with persistent, permanent or chronic atrial fibrillation. The risk is the same, and according to the SHAD-VASc score, we decide to give oral anticoagulant. For the patient with paroxysmal atrial fibrillation, we have to give oral anticoagulant according to the SHAD risk score, because the risk is the same as those with permanent atrial fibrillation.
Okay, thank you. Another question برضو لدكتور طارق regarding the use of aspirin for patients with AF. Can I use aspirin for stroke prevention في العيان اللي هو عنده atrial fibrillation or not?
Unfortunately, some doctors prescribe aspirin for patients with atrial fibrillation. Aspirin is contraindicated, class 3 recommendation. There is no prevention for ischemic stroke or thromboembolic manifestation. The aspirin should not be used for patients with atrial fibrillation. Oral anticoagulant, not to use aspirin. It's class 3.
Okay, thank you so much. Dr. Ihab, a question for you regarding patients with age above 75 years old. السؤال regarding the dose of Xarelto for those patients, should the dose be reduced or not?
Very good question. When we're talking about rivaroxaban and Xarelto in particular, if we look at, like Professor Tariq Zawawi showed us elegantly, multiple studies for patients above the age of 75, and in the Rocket AF study there were like more than 40% above the age of 75, and there was no reduction in dosage. The reduction in dosage with rivaroxaban or Xarelto will depend on the creatinine clearance. So with the elderly per se, for age, we do not reduce because they are above 75, but we have to accurately calculate the creatinine clearance, and this will take into account the body weight and the age of the patient when we do the calculation. So as long as the calculation shows us it's above 50, then we're going to stay with the 20 milligrams. If it's between above 15 and below 49, then we'll go with the 15 milligram because of the creatinine clearance, not because of the age. So to answer your question, above 75 with a normal renal function will take the full dose, 20 milligrams, with, as was shown in the ROCKET-AF, with less events compared to warfarin.
Okay, thank you so much. And another question regarding if the patient is on dialysis below 15 milli per minute, should he take NOACs or not?
Classically speaking, when we go below 15, we do not have a solid recommendation. However, on the other side, there are small studies that came particularly in 2019 and 2000 and early 20 that have used Xarelto in patients with, of course, with a reduced dose, 15 milligrams, in patients with stage 5 chronic kidney disease and even some on intermittent dialysis, and they had no problems there. But they did not get that approvable for using it on dialysis. But these studies reassure us that it is relatively safe, and I expect in the near future that we will get recommendation probably for that chronic kidney disease stage 5 patients. But until we get this firm recommendation, we will stay without using them if we can avoid that.
Okay, thank you so much. Last but not least question برضو لحضرتك دكتور إيهاب regarding compliance. يمكن حضرتك you focused on this point with once daily versus twice daily. Does it really help your patients in being adherent to their medications? وهل يعني does it really make a difference with your patients or not?
Yes, it makes a difference because I always make it a point to tell my patients the frequency of the medication I'm giving them. For example, when I'm giving an antihypertensive medication, I tell them this is a once daily or this is twice daily because it's not covering the 24 hours. When it comes to NOACs, and we have only Rivaroxaban currently in Egypt, I'm talking about Egypt, not other countries, that is once daily from the new oral anticoagulants. So I'm telling them this is a once daily that you take in the evening with meals, and you make sure you take it every night with your evening meal. So the patients, most of them prefer the once daily. They always want the simple dosing, and they want it compared to the twice daily. In addition, patients who fast, like those when we come to Ramadan and the fasting, we have a lot of patients who fast outside of Ramadan, and they want something that is once daily and easier for them to use when they fast. So Rivaroxaban or Xarelto will make their life much easier. So yes, to answer your question, I found that a single daily dose makes their life easy and simple.
Okay, thank you so much. حابب أشكر حضرتك مرة تانية، وطبعا بروفيسور طارق for your elegant presentations and elegant moderation. وطبعا كل الدكاترة اللي شرفونا النهاردة in the webinar. stay safe ونشوف حضراتكم عن قريب إن شاء الله. Thank you so much.
Thank you very much, everyone.
شكرا.